Welcome to ACLSMED. Today we're managing a critical case of symptomatic bradycardia in an older adult. Let's review the situation before we assess this patient. Our patient is Dorothy Flanagan, 78 years old, female, weighing 61 kilograms. She is currently in a hospital bed on the critical care unit. Dorothy was admitted this morning after becoming pale and confused at her assisted living facility. EMS brought her in with a reported heart rate in the low 30s. Chief complaint: severe bradycardia with altered mental status. History: Dorothy has a medical history of sick sinus syndrome, which is not pacemaker dependent. She has hypertension, chronic kidney disease stage 4, hypothyroidism, and has fallen twice in the past 6 months. Critical detail on medications: Dorothy is taking metoprolol succinate 200 milligrams daily, which is a beta blocker. She is also taking diltiazem extended release 240 milligrams daily, which is a calcium channel blocker. This means she is on double AV nodal blockade. Combined with her stage 4 chronic kidney disease, which impairs how quickly her body clears medications, this is a recipe for severe bradycardia and hemodynamic collapse. She also takes lisinopril for blood pressure, levothyroxine for her thyroid, and calcium carbonate as a supplement. This is a medication-induced bradycardia until proven otherwise. Let's begin our assessment. Upon arrival at her bedside, we find Dorothy lethargic but rousable to voice. She is oriented to her name only. Her skin is pale, cool, and diaphoretic. Her airway is patent. Her lungs are clear bilaterally. She is breathing spontaneously at a rate of 10 breaths per minute. Her vital signs are concerning. Heart rate is 34 beats per minute. Blood pressure is 78 systolic, 42 diastolic. Her oxygen saturation is 93% on room air. Temperature is 35.9 degrees Celsius, indicating mild hypothermia. End-tidal carbon dioxide is 30 millimeters of mercury. On physical examination, her skin is pale, cool, and diaphoretic, indicating poor peripheral perfusion. Her capillary refill is 4 seconds, which is delayed. Her peripheral pulses are weak. These are signs of shock. Let's look at her cardiac monitor. We see sinus bradycardia at 34 beats per minute. The rhythm is completely regular. P waves are present and upright, appearing before each QRS complex. The PR interval is normal. The QRS complex is narrow and normal morphology. There is no evidence of a conduction block at the level of the PR segment. This is a sinus bradycardia, not a heart block. However, this patient is symptomatic. She has altered mental status, she is hypotensive, and she shows clear signs of poor perfusion. This is not a watch-and-wait scenario. This patient needs immediate treatment. Applying the ACLS bradycardia algorithm. Is the rhythm bradycardic? Yes. Is the patient symptomatic? Yes. Are the symptoms caused by the bradycardia? Yes. This is a symptomatic bradycardia with hemodynamic compromise requiring immediate intervention. Our first step is to establish IV access. We place a large bore IV line, 18 gauge. We apply supplemental oxygen to target a saturation above 94%. We place her on continuous cardiac monitoring. We notify hospital command, cardiology, and prepare the ICU for her admission. Now we administer our first-line agent for symptomatic bradycardia, atropine. We draw up 0.5 milligrams of atropine, which is 0.5 milliliters of the 1 to 1,000 concentration. We flush the IV line with saline and push the atropine IV rapidly over 1 to 2 seconds, followed by a 5 milliliter saline flush. We watch the monitor carefully over the next 30 to 60 seconds for a response. 30 seconds have passed. We reassess Dorothy. Looking at the monitor, we still see sinus bradycardia at 34 beats per minute. There has been no change. Her heart rate remains 34. Her blood pressure is still 78 systolic, 42 diastolic. Her skin remains pale and cool. Her mental status has not improved. The atropine has not worked. This is not surprising. Dorothy's bradycardia is being driven by the direct pharmacologic effects of the metoprolol and diltiazem on her SA and AV nodes. Atropine enhances the intrinsic function of these nodes, but cannot overcome the strong blockade created by her medications. Her chronic kidney disease means these drugs are accumulating in her system and are very active. She needs an external pacemaker. We need transcutaneous pacing. We expose Dorothy's chest and prepare the skin. We place the negative, or white, pacing pad on her right anterior chest wall, just below the right clavicle. We place the positive, or red, pacing pad in the fifth intercostal space at the mid-axillary line, at the level of the nipple. We press both pads firmly for 10 seconds to ensure good contact. We connect the pacing cables to the defibrillator pacing unit. Before we initiate pacing, we give Dorothy analgesia and sedation. We administer midazolam 3 mg IV push to reduce her anxiety and discomfort during pacing. Now we set the pacemaker to demand mode at a rate of 60 beats per minute. We begin at 0 milliamps and gradually increase the output, watching the monitor and palpating for a pulse. We increase the output to 10 milliamps, then 20, then 30, watching carefully. At 75 milliamps, we see electrical capture. A pacing spike appears on the monitor before each QRS complex. The QRS is wide, as expected with ventricular pacing. We palpate the femoral artery and feel a strong pulse at 60 beats per minute, regular and synchronous with the pacing spikes. We have mechanical capture. The pacemaker is working. Now let's reassess Dorothy immediately after we initiate pacing. On the monitor, we see a paced rhythm at 60 beats per minute, regular, with pacing spikes before each QRS. Her vital signs show immediate improvement. Her blood pressure is now 88 systolic, 48 diastolic. We can already see an upward trend from 78/42. Her oxygen saturation is 95% on supplemental oxygen. Her skin is becoming warmer and less pale. She is more arousable and beginning to answer questions. Her capillary refill is improving. Her peripheral pulses are stronger. Transcutaneous pacing has restored her heart rate and improved her perfusion. However, this is a bridge, not a definitive solution. We have not yet addressed the underlying medication toxicity. She still has the metoprolol and diltiazem on board. We need to give her reversal agents. For the beta blocker toxicity from metoprolol, we are going to give glucagon. We draw up 5 mg of glucagon and push it IV over 1 to 2 seconds. Glucagon works by bypassing the beta blocker blockade and directly enhancing myocardial contractility and AV nodal conduction. We also need to reverse the calcium channel blocker toxicity from the diltiazem. We draw up 1 gram of calcium chloride, which is 10 milliliters of 10% solution. We push the calcium chloride IV over 2 to 3 minutes through our large bore IV. We use the large bore line to minimize the risk of tissue damage from calcium infiltration. While these medications work, we continue pacing at demand mode. We keep the pacemaker ready to provide a rate if Dorothy's intrinsic rate drops below our set threshold of 40 beats per minute. We wait 5 to 10 minutes for the medications to take effect. Now let's reassess. On the monitor, we see an intrinsic sinus rhythm emerging. Dorothy's own heart rate is now 54 beats per minute. The rhythm is regular with normal P waves and normal PR intervals. Her heart is taking over from the pacemaker. She no longer depends on the pacing for adequate rate. Her vital signs show significant improvement. Her heart rate is 54 beats per minute. Her blood pressure is 94 systolic, 50 diastolic, continuing its upward trend. Her oxygen saturation is 96% on supplemental oxygen. Her capillary refill is normal. Her skin is warm and pink. Her mental status has dramatically improved. She is now alert and oriented to person, place, and time. She is no longer confused. She reports feeling much better and is no longer dizzy or nauseated. She can move all 4 extremities. She is conversant and making sense. We have successfully reversed the hemodynamic collapse. Dorothy's bradycardia has been managed. Her perfusion has been restored, and she is clinically improved. We still have important next steps. First, we hold her metoprolol and diltiazem to prevent recurrence of bradycardia. We will coordinate with cardiology about restarting these medications at lower doses or with different agents that are safer for her. Second, we leave the pacing pads in place in standby mode. If her rate drops below 40 beats per minute, the pacemaker will automatically engage. We remain on continuous telemetry. Third, we continue to address her laboratory abnormalities. Her potassium is elevated at 5.4, which can contribute to arrhythmias. We may need to give potassium-lowering therapy. Her troponin is elevated at 0.04, and her BNP is elevated at 185, suggesting cardiac stress and possible demand ischemia from her severe bradycardia. We will draw serial troponins and continue EKG monitoring. Her hemoglobin is low at 11.8, which means her heart tolerated the bradycardia even worse because her blood cannot carry as much oxygen. Fourth, we consult with cardiology. Given Dorothy's sick sinus syndrome and her medication-induced bradycardia, she may benefit from a permanent pacemaker. This is a conversation for her cardiologist and her, but it is an important consideration. Finally, we ensure Dorothy is admitted to the ICU for continuous monitoring, possible transvenous pacing if needed, and comprehensive care of her underlying conditions. Let's review the key teaching points from this case. Dorothy Flanagan arrived in severe shock from bradycardia. Through systematic ACLS management, we recognized her as a symptomatic patient requiring immediate intervention. We administered atropine as first-line therapy. When atropine failed, we rapidly escalated to transcutaneous pacing to restore her rate and perfusion. We then gave targeted reversal agents, glucagon for the beta blocker and calcium for the calcium channel blocker, to address the underlying medication toxicity. Through this systematic approach, we prevented cardiac arrest and restored Dorothy to a state where she could be admitted to the ICU for definitive care. The critical learning points for your practice are these. Patients on double AV nodal blockade with a beta blocker and calcium channel blocker are at high risk for severe bradycardia and AV block, especially if they have renal impairment. This should trigger a medication review. If a patient is bradycardic and showing signs of hypoperfusion, altered mental status, hypotension, or poor skin perfusion, they need immediate treatment. Do not wait. Atropine is first line for symptomatic bradycardia, but in medication-induced bradycardia, it often has limited effectiveness. You must be ready to escalate to pacing if the patient remains symptomatic. Transcutaneous pacing can be placed in minutes and immediately restores rate and perfusion. Know your reversal agents. Glucagon reverses beta blocker toxicity. Calcium reverses calcium channel blocker toxicity. Renal disease impairs drug clearance and increases the risk of medication toxicity. Finally, elderly patients tolerate bradycardia poorly. They depend on heart rate to maintain cardiac output because they cannot increase their stroke volume as effectively as younger patients. A heart rate of 34 in an elderly person can be catastrophic. This case demonstrates the power of ACLS, systematic assessment, rapid recognition of the problem, immediate intervention, and clinical reasoning to manage the underlying cause. Dorothy is now awake, alert, and on her way to the ICU for definitive care. This is ACLS in action.
Integrated, immersive, essential. ACLSMED.com. Go practice today.